Team, welcome back. Another Thursday VMR, this time with much less external enthusiasm owing to ER nights induced fatigue, but the same internal level of enthusiasm because of the privilege I have to share the stage with Vinny. It's really not an overstatement to say that our beloved Vinny does not need any intros into the CPS world. He has presented more cases than I have fingers, which is a lot more than many. And has mentored many people uh, in the world of CPS, and is recently now one of our new leaders in the case review committee. And whenever somebody has a leadership position in the realm of CP solvers, you know they've been at it for a while and been doing an amazing job. So very, very excited to get to share the stage with you, Vinny, today. How are you feeling? Are the nerves kicking in, or are you a little bit more comfortable than usual?
Yeah, well, thank you for your kind words, Ravi. And we're so fortunate to be in part of the space and sharing the knowledge between seasoned physicians and beginners and medical students. So it's an opportunity equal to none. So besides from that, I'm just doing chill, everything okay. Currently finishing my medical school and excited for what is about to come. And yeah, thank you so much.
Oh my gosh, I'm so sorry. I lost your audio for a second. There we go. Can you hear me okay?
Yeah, I can hear you.
Until the last moment, and then my mic decided to take over the audio. Um, how are the nerves?
Oh yeah. I'm always like struggling with that, but I'm trying to keep myself calm. It's a
Yeah,
long journey. It's a long journey.
100%. If the patient's vitals are stable, so should we. So sit back, relax, enjoy. Big shout out to Simi who is scribing and Eugene who is doing teaching points. Maybe we could hand the mic to you all respectively and then introduce our case presenter.
Hello everyone, happy Thursday. And Prani's last case left me dizzy with the complaint of dizziness. And let's see what he has today. And very excited for discussion by Rabih and Vinny. Looking forward to it.
Hi everyone, my name is Eugene, physician from Ghana. Always an exciting space to share this VMR sections with the family. I'm actually excited to hear from Vinny today and also for Pranay's case. Yeah.
Oh my gosh, that sounds absolutely wonderful. Pranay, you're being hyped up like no other because this is case number what in VMR? Pranay is one of our longest VMR community members, and he's back for another one. Very, very excited for your case, Pranay. Do you want to update the VMR crew on where you've been and how you've been?
Sure. So hello everyone. I'm Pranay. I'm one of the second year intern medicine residents from New Jersey, and yeah, it's been pretty busy. Just started second year 1 month ago, and I was doing IC for 4 weeks, and it was I was just speaking with the team. It was an amazing experience and learned a lot of things. In terms of today's case, it is a very special case for me because like the in terms of diagnosis and couple of things like how we reached the diagnosis and when actually I got to know about the diagnosis and the case, I thought that this would be a perfect case for CP solver. So I'm also very excited about this case today.
Vinny, how are the nerves now?
I'm sorry, getting more excited.
Well, at the end of the day, we're very, very excited to learn and dissect your case. And I'd encourage all of you to realize that you're going to be in this situation no matter what, either the whole case or a small aspect of the case, be it meeting the patient in the emergency room or in the clinic or taking care of the patient wherever they end up. So let's hop in and take care of this patient together. And we'll do our best and certainly learn a lot along the way. So, Pranay, take it away whenever you're ready.
Sure. So for first aliquot, I have a 42-year-old male who comes with complaint of numbness on left side of body and difficult to move left side of face.
So, Vinny, what are you thinking with this information? It's definitely not complete, but what thoughts are crossing your mind?
Yeah, so I'll be concerned about the tempo now from that is occurring, and if is the numb, or we already know that's just in the left side of the body and the left side of the face. So it's intriguing because there's no right space that is involved in that. And I would be excited to know if there is a common pattern between the numbness, if in the toes is equally to the like in the thigh and equally in the abdomen, if the reflexes are present. So that's what comes to my mind first, and try to see and characterize or what and also what the patient understand by numbness, and it's just a feeling of not feeling the limb or the part of this body per se, or is the sensation of cold and hot preserved, and yeah, I would be intrigued by those characteristics, and what are your initial thoughts about it?
Yeah, like you, I parked my thoughts, Vinny, at what's the time course, because no matter what other details we get, if we learn that this is 1 hour old or 30 minutes old, it doesn't matter what the details are. And the reason why it doesn't matter is the patient is presenting with a unilateral neurological deficit. And whenever somebody presents with a hyperacute unilateral neurological deficit without any other information within the time frame of the intervention of a stroke, you would probably activate a code stroke. So for me, it goes to show you how powerful knowing the space here, neurology, and time continuum is. Without the time, you don't know what the right thing to do right is. Is the right thing to listen to great detail for the patient, or is the right thing to skip over the detail now and start to focus on a life-threatening cause? So what I'm thinking is, I cannot think. This patient has triggered a reflex, and that reflex is this a stroke or not? And so I wouldn't really be thinking of beyond that apart from knowing the time course. And the question is, can you make some inferences on the time course um, based on the presentation? And I think that it's interesting that the patient's symptoms of numbness and motor weakness are on the same side. And so if it is a stroke, it cannot be, well, it can, with very rare exception, be a brainstem problem. If you might remember the simple rule about brainstem having crossed signs. And I should just be clear, I started with the brainstem because Vinny, the patient's face is involved. And so that mandates involvement of that spares the spinal cord and tells us that it's something brainstem or above, if it is central. It, of course, could be peripheral. But then it would have to be either lacunar phenomenon or a cortical stroke. And so is it possible? Yeah, I think if he has a right-sided lacunar infarct or a right cortical infarct, it would be very, very possible. So I wouldn't be thinking beyond that and would just be really curious to know what the time course is. And if the time course is anything but hyperacute, then we get to nerd out mega. So I hand the mic to Pranay to tell us more.
Great discussion. So for Aliquot number 2, so we have a 42-year-old male with past medical history of chronic pain, recurrent DVT, and PE status post IVC filter insertion. Also history of bilateral blindness, hearing loss, who comes to the ED with complaint of progressive numbness on the left side of the body and difficulty to move left side of face for past 15 days. According to the patient, he says that it's sometimes it comes and goes, but for past couple of days, 3 to 5 days, it's been getting progressively worse. And he also reported difficulties in eating and drinking, as he's not able to move his left side of face that much. Additionally, he reported episodes of non-bloody, non-bilious vomiting and a non-traumatic progressive left hip pain for past 10 days. I'll also give you past medical history. So patient has past medical, it's kind of extensive past medical history. So legal blindness, patient has history of legal blindness, secondary to uveitis, status post bilateral enucleation. Also has history of hearing loss, that is only partial hearing loss. At that time, it was not made sure that if it's sensory hearer or audio, other type of hearing loss. There is questionable history of pontine mass, but again, patient is not sure about that. There is history of recurrent DVT and pulmonary embolism, status post thrombolysis twice, and IVC filter insertion, and also history of chronic bilateral lower extremity pain. Patient has history of recurrent ED visit for the same complaint of bilateral lower leg pain and swelling, and also occasional pain in the hips. And the patient, again, as I said, that patient was admitted for recurrent DVT and pulmonary embolism at least 3 times, and 2 times among that patient had to be thrombolized. And also, it was reported that patient has failure to apixaban, dabigatran, and warfarin. So that's all of the past medical history. For social history, patient's unemployed and he reports that occasionally smokes marijuana, but he denies any history of smoking, alcohol use, or any other drug use. There is no significant family history. And for medication, patient currently is on Lovenox BID, enoxaparin BID for anticoagulation for DVT and PE. Also, patients on oxycodone, acetaminophen as needed, naproxen as needed, gabapentin, and cyclobenzaprine. And this is the end of Aliquot number 2.
Oh my gosh, Pranay, what just happened? So Vinny, I'm curious. I think it's not a good idea to try to analyze everything here and try to get as much information from each piece because you'll end up with cognitive overload. So I'm hoping that you can teach the junior members who are here of everything you just heard, so many things. What is the top thing that is grabbing your attention? Triage for us here.
Yeah, so it's it's hard to see what is the most because there is plenty of things that is happening here. One thing that makes me very worried is about the like prothrombotic state that this patient has with multiple hospital admissions and failure to treatment
Yeah.
for anticoagulation. And but also it is how to correlate this clinical scenario with the presentation of the
Yeah.
of his chief complaint, because
Right.
the chief complaint is what worries the most
Absolutely.
for this patient at that point.
Beautiful.
So even though like he was admitted for PE multiple times, so maybe like the short he is used to being like, I don't know, short of breath at baseline. I'm just like doing a supposition.
Yeah.
But then the numbness is very worrisome
Right.
for him per se.
Right.
So I would think that these two pillars, it's
Yes.
what gets me the most attention.
Wow. Look at you using fancy words. Pillars, huh? Wow. My gosh, that's amazing. Those are my two pillars too. I think that when you have such unbelievable hypercoagulability, it's hard for that not to end up having a very specific diagnosis. And that's very counter to many people who have hypercoagulability of unclear etiology, but the signal here is strong for two reasons. The first is how refractory and severe it is, but also the fact that it's associated with a systemic syndrome that is not yet characterized. Bilateral uveitis is not a diagnosis. Bilateral hearing loss is not a diagnosis. These are just beginnings of the journey for the patient, and we have to figure out what the underlying cause for each of those things is. And it's tempting not to think that they're unified by something given the patient's young age. And so I think that, yeah, I think that we have a very, very important landscape to analyze here. But as you said, we have to put together the patient's new symptoms with the most powerful piece of medical history, and that is the thrombolysis. So can you think of a way that hypercoagulability can cause his neurological symptoms right now. And I'll just say that you might think, oh, could he have an acute stroke? But for 15 days, that's very weird. So can you think of a way that a hypercoagulability can cause a syndrome like this? What do you
Yeah, I
think?
was thinking that there's the vasovasorum, the vasonervorum, and if you have like a
Yeah.
pro-coagulation state
Mhm.
in this micro environment, and like blood is not getting there, and like nerves could be suffering, or um, besides that, it's I think that, for example, if you think about um, the arteries that goes along in the ventral and the dorsal face of the column, and other spaces also, if they are compromised, the patient will suffer consequences and will suffer not just like the one finger will suffer from the entire
Right.
body as this patient is suffering. And so I would try to correct that. Another thing that I was thinking about is trying to localize the lesion
Mhm.
here. And I'll, due to the fact that he's the entire left side, I would think about something central and more to the brainstem, or like, or even yeah, just the brain or the medulla. But yeah, I think that I was about to go in this direction. What thoughts do you have, Rani?
I agree with you. I'll give you a simple way of thinking about it. Whenever you're thinking about subacute ischemia, so you have subacute from the story, and then you have ischemia based on hypercoagulability. There's two really important diagnoses. The first is a venous infarction. So if he has a dural sinus thrombosis and subsequently has a hemorrhage of one of the cortical veins, that can easily result in a subacute presentation. That's probably the numbness diagnosis here. Alternatively, as you said, he could have diffuse capillary involvement as part of microthrombosis like TTP or vasculitis, and that can present in a subacute manner. So I think when you see this patient in real life, you probably look at his chart and you say, wow, there's so much to sift through here. The mistake that you might make in real life is to be tempted to try to put it all together now. But I think you have the opportunity to finally get clarity on one aspect of his disease, which is the neurological aspect. Because it's very different to say uveitis, hearing loss, hypercoagulability of unclear radiology, than to say uh, large right-sided mass. And I think we finally have the ability, with how devastating his disease is, to clarify what the neurological elements are and move forward. I think it would be very, very premature and probably cognitively unwise to think of a diagnosis now without first clarifying what the neurological elements of this case are. So we have a lot to work with, and I think we'll end up going back to the history and reanalyzing what's the deal with the hip pain, what's the deal with this and that. But imagine you're in the ER and you're thinking about this person's uveitis while they can't move their face. People would laugh at you. So let's focus on the neuro element, and then we'll see how we can come back and unite these things. All right. Oh, go ahead, Vinny. You were going to say something?
No, no, absolutely. And just the uveitis makes me think more towards a autoimmune and a chronic inflammatory state. And then we will like open the bucket for rheumatologic uh, diseases. But I will leave by that at this moment, and just leave this differential diagnosis in my mind. So when we
Yeah,
have more data, we can dive deep.
100%. 100%. All right, Pranay, we're very, very intrigued. What do you
Uh,
have?
Great discussion. So for third aliquot, For his vitals, on arrival, he was afebrile. Heart rate was 80 beats per minute, blood pressure of 126 over 88 millimeters of mercury. He was saturating 98% on room air, and also respiratory rate was normal as well. For physical examination, general appearance normal, again, no acute distress. For head and neck examination, patient has bilateral enucleation, and also cardiopulmonary examination is pretty much normal. Some acne were noted on the face as well. And for abdominal examination, soft non-tender abdomen. For neuro examination, muscles. So again, patient was alert oriented times 3. Muscle strength was 5 out of 5 bilaterally. Sensations were intact, and patient had some left-sided facial weakness, but other cranial nerve examination was pretty much within normal limit, and reflexes were normal in all 4 extremities. And to mention on extremities, bilateral lower extremities, patient had 1+ swelling and also generalized tenderness. For basic labs, do you want me to give you the basic labs, or do you want to keep it?
Yeah, please go for it. I can tell this case is very juicy, so why don't you give us the basic lab?
Sure. So for labs, CBC, white blood cell count of 13.8 with normal differential, hemoglobin of 11.8, platelet count of 451,000. CMB was pretty much within normal limit. Lactate was normal. INR was within normal limit. UA was performed, which was normal, and UTOX was positive for barbiturates and THC. ESR was elevated at 127, and CRP elevated at 90. EKG was also performed on arrival. That was normal sinus rhythm. And additionally, CT head and CTA head were obtained stat, which did not show any abnormality. There were no acute intracranial hemorrhage, mass effect, or midline shift. CT head did show some stable sub-centimeter pons, lacunar infarct, and stable atrophy of the globe. And CTA chest was also done because of history of PE and that type of presentation, and there was no PE on CTA chest. And that's end of Aliquot number 3. And I would also like to ask everyone which additional labs you would like to order.
Amazing, yeah, Pranay, thank you so much. So, Vinny, let's focus on the neuro element. So, what did you make of the neurological exam?
Yeah,
Yeah,
I was expecting like a worse
yeah.
exam, and it doesn't look like the patient is looking bad. He has like vitals normal. He refers severe pain from severe pain and numbness from what we from my understanding. And just the what intrigues me is just the left-sided facial weakness. And what about the all the numbness in the left body? There's no comments about that. So that's a thing that um, I keep in my mind, but there's no component of motor. Yeah, it's not affected the motor part, so it's preserving the use of motor, yeah, of the motor vs, and the reflexes are normal also. So I don't know how can we make progress just with the left facial weakness, and then we can, as you predicted in the beginning about the lacunar thing. But regards the exam, I'll stop here, and then we can go to the other data. What
Yeah,
do you think, Ravi?
I'm right there with you. I was also underwhelmed by the neurological exam. It's really not too bad. I would be really curious to know if the left-sided facial weakness is in an upper motor neuron pattern or a lower motor neuron pattern. That would be pretty informative to understand where the lesion might be. So, Vinny, how would you distinguish the two? Do you know how to tell if it's upper motor neuron or lower motor neuron? Have you learned this?
Yeah, it's been a while since I saw that, but it's like dividing the face and then doing some kind of stimuli and see if the patient can do the smile and if like the patient can move or not. just the lower part, or cannot move the entire part, or something like that. I confess that I don't remember specifically.
Yeah, I am right there with you. I think that you can make a lot of progress with this. And the simple way to think about it, Vinny, is the lower motor neuron, the facial nerve, innervates the whole face. And so when there's lower motor neuron facial palsy, the whole face is dysfunction, upper and lower. When it's central, there is innervation to both sides of the upper face. So if one side is diseased, the other side can compensate. So it's a little bit surprising, but the more weakness the patient has, upper and lower, the more reassured you should be. And the more sparing there is of the upper part, the more worried you should be. It's very weird. You walk in, you see, oh, the patient can move their eyebrow. Whew, good. And so I'm curious, Pranay, do you happen to know if it's in the upper motor neuron or lower motor neuron?
Yes, sorry, I forgot to mention it actually. So it was more like an upper motor neuron type.
Upper motor neuron type. See, now I think, Vinny, that's why it's such a powerful thing, right? And now I think you'd be very worried that the patient had a central process going on. And so what do you think your next step might be to clarify what this lesion represents? What kind of test do you think you want to further make progress?
Yeah, so we already had the had CT that is non-contributory in, and also there's the lacunar infarcts. I think that the most prevalent one is the MRI. But in the setting of we are in the emergency department, these tests would be out for the floors and for the subsequent days. And but yeah, just regarding the imaging, also I don't know if we can do how pertinent is an electroneuromyography in this sense for this patient. And do you have any thoughts in regards to that, Ravi?
Yeah, I mean, I think the fact that we localize it to the central nervous system because it's upper motor neuron means that I think trying to figure out where in the central nervous system it is it parenchyma, is it ventricle, is it vascular, or is it meninges? And I think here, based on the unilateral weakness, it very likely is in the parenchyma. And so I think an MRI with and without contrast will be very, very illuminating. So we have that to understand the brain element. What did you think about the systemic element with the labs and the systemic image?
Yeah, so now going to the labs and the other data, the WBC being elevated, but with neutrophilic differential. In this setting, with the absence of fever and the absence of presumed like infections and for what comes until this point, I'm not very concerned about an infection, but we need to keep that as a differential. I think that these points, and now alongside the CRP and the ESR points to the chronic inflammatory state that we talked before, and the U talks and just like the patient has a habit of smoking marijuana and doing drugs. So I didn't know it's a knowledge gap if there's anything regarding these kind of toxins that can manifest with the neuro symptoms that we are seeing thus far. And the hemoglobin from I don't know the reference value for his lab, but it's would be like in the lower threshold maybe, and the platelets it's just normal from what I'm seeing. So there's no reactive um like plaquetosis or thrombocytosis, as the right word, and so that's okay. And what else? Like the CMP is non-revealing, and the patient does not have any liver function test that can point towards any kind of differentiation that I don't know here. And yeah, I think that that's in a general way, in general manner, points towards a a chronic inflammatory state, and then we'll need to open the buckets of diseases that can manifest subacute, but they will be like installed from a long period of time and just with clinical manifestations uh, after after a significant period that the patient already has that.
Yeah, I'm right there with you. I think whenever you have neutrophilia, you have to worry that the patient doesn't have an infection. But I think the time course here is very, very intriguing. And the only conclusion I've come to, Vinny, is this case is very, very unusual for many reasons, but it's unusual because most of the time, whenever somebody has a unilateral neurological issue, the disease begins and ends in the brain. You know, if you have demyelination or primary CNS process, there's usually no systemic fingerprint. So I think you can come to the very likely conclusion that this patient has a systemic disease affecting their brain. And no longer is it just a brain restricted problem, because before we had just heard about the brain, the eyes and the ears, and those are all very, very central organs. And it could be very, very reasonable the patient has only a neurological element to their disease. Our hint that they have a systemic component was the fact that they were really ultra hypercoagulable. But I think now with neutrophilia, thrombocytosis, and with the high CRP and ESR, this patient has a systemic disease. And the question is, what is that systemic disease? And I think we'll be able to make a lot of progress once we understand what the imaging looks like and to see where that takes us. I don't think there's any empiric treatment that I would do right now, but I will note that most of the time when somebody has a brain mass, which is a thought that should cross our minds right now, when somebody has a subacute neurological element, most brain masses come to most brain masses are cancer, and most cancers come from the skin, melanoma, or the lungs, lung cancer. And the fact that a CT chest is clear is very, very reassuring. I do not expect him to have metastatic disease to the brain. So the question is, does he have a primary brain tumor, or does he have a non-mass forming process? And I suspect that the lack of a headache is another clue that we might not have a mass after all. But very, very interesting. What do you have next for us, Pranay?
Amazing discussion. So for the next aliquot, I have some basic labs. So initially, like as a part of the whole workup, HIV, syphilis, and gonorrhea, of course, were performed, which were pretty much negative. MRI of the brain with contrast was performed, which actually showed that there are multifocal areas of T2 hyperintensity signal with mild mass effect involving the right hemimedulla, right dorsal pontomesencephalic junction, right dorsal pons, and extending to involve right dorsal slash lateral midbrain. And they also mentioned that more focal areas of T2 hyperintense signal, which probably represent chronic lacunar infarct, are noted within pons and basal ganglia. There is no acute hemorrhage. MRA of the brain was also performed, but it did not show any vessel occlusion. And MRI of spine was also performed, which was within normal limit. CSF analysis was also performed, which showed that appearance was clear. The opening pressure was normal, no RBCs. White blood cells count elevated in CSF at 160, neutrophil 85%, and protein was elevated as well, 76. CSF cultures were negative, and as a part of workup, X-ray of the knee and hip was also performed, which was normal. And eventually, as patient was complaining of persistent hip pain, MRI of hip was performed, which was also negative. So that is the end of aliquot number 4.
Vinny, I have to be honest with you. I think I know what he has.
Do you think?
I think it's not good.
Or
So my goal is to try for us to be dancing well together. But is it
all right?
really fair to expect somebody who hasn't done their intern yet to solve a case that's this complicated? No. So let's take some time together to discuss this. I'm curious what you are thinking of the MRI. How did that help?
Just the weakest point, yeah. while Renee was like seeing the MRI, I was just please Rabih interpret the MRI, please. But anyways, yeah, the MRI, from what I can grab from that is the reintegrates the lacunar involvement, the pro-thrombotic state, and I am not certain at all how to localize it specifically, and if that will change anything in the clinical reason, because yeah, because I don't know, but
Let
I'll
me guide you to one key part. What part of the brain is affected?
is that like there is the basal ganglia from seeing
So I'll read to you.
no, okay,
Medulla,
Mandela.
pons, midbrain.
Okay.
Yeah. Medulla, pons, and midbrain. What structures does that make you think of?
Oh, that's hmm.
That is all brainstem,
Yeah, okay.
right? So why would a young man have such horrific disease in his brainstem? And the answer to that really comes from first studying the peripheral signature. So we said we would talk about it later. So I'd be curious now to go back and leave the brain for a minute and ask you, when you think about somebody who is clotting so much like this, very hypercoagulable, what diagnoses do you start to think of with such severe hypercoagulability?
Yeah, I was about to think about antiphospholipid syndrome.
Good. Good.
Yeah, Behçet's, let me see, DIC, but the normal platelets we talk against it, and Sjogren, but I don't think that Sjogren. I think that I know that it is. It's not uncommon to have neurologic manifestations, but the clinical picture without like any mention of saliva symptoms, is not very concerned about that. But in the other part, the patient had uveitis and had complications secondary to the uveitis, and so that's a point that intrigues me also. So, and but the thing is that about coagulation, like what about the PTT, the PET? Like there's the normal NRI for what we have. We don't have like haptoglobin or LDH, but I don't even know if these will be super pivot to think about those diagnoses. I think
Yeah.
that history is more important.
You're right to study the hematological parameters as best as you can, because most of the time somebody has a really hypercoagulable condition. You can break it down into intravascular versus extravascular. And the vast majority of time when somebody is clotting a lot, they have a pure intravascular disease. And you will find nothing outside of blood vessels. TTP, DIC, APLS, heparin-induced thrombocytopenia, hypereosinophilia. There is no extravascular fingerprint in all those disorders. So, as a secret between me and you and everybody who's watching this recording, this case is very easy to solve once you realize there are only 3 conditions associated with severe hypercoagulability and prominent manifestations outside of blood vessels. Cancer, the most common cause of hypercoagulability with extravascular disease. Behçet's and VEXAS syndrome. There. Is this cancer? He's been suffering for how long? Is this VEXAS? Too young. So now the question for you and me is there, what are all the clues that this could be Behçet's? So what are when you look back at this case, what are the things that jump out to you that could be consistent with Behçet's?
Also, Bobby, besides it's a knowledge gap for me, but I don't know if how or the could be the manifestations from the neurologic manifestations for Behçet's per se, but I would expect that the patient also had after ulcers, oral ulcers, or he indeed had the genital ulcers. So that's a point that
Wow.
corroborates what we're thinking. There's for what we're seeing besides the genital ulcers, there's no comments from other skin lesions, and yeah, I think that there's like criteria from symmetry of points, but I'm not 100% sure what those criteria are.
Yeah, I think the criteria for Behçet's is very much a clinical syndrome, and he has met criteria a long time ago. Uveitis, genital ulcers, acneiform rash, hypercoagulability refractory to treatment, and unfortunately, likely influenced by the delay in diagnosis, horrific brainstem disease. The propensity for brainstem involvement of a systemic disease that is subacute is very small differential diagnosis, and it includes Behçet's disease.
Mhm.
But I have yet to tell you all what I think is the most specific feature of Behçet's. And I think, Vinny, it's his LP. You may be like,
Well,
Bobby, wow, you must have worked very hard on your night shift and you must be very confused, which is reasonable. But can you guess, Vinny, what about his LP is weird?
because does not point any and does not point to any other thing that could be like malignancy or infectious causes or uh, anything. So we can rule out confidently what is not to be in data with the clinical scenario and the criteria. That's what lacks to us and makes more sense in regards to history.
Yes, that's definitely true. The fact that you don't have a positive culture, you don't have positive cytology. But let me ask you this. When somebody has had 2 weeks of symptoms, what is their typical differential on the white blood cells count? Neutrophil or lymphocyte?
2 weeks, I would bet neutrophilic
It's
and
usually lymphocytic. Neutrophils are
lymphocytic.
very acute. 1 hour, 1 day, 2 days, and then they go away. When you tell me a patient has a subacute neutrophilic pleocytosis on their lumbar puncture, I tell you it's either Still's disease or Behçet's. Very, very unusual to have neutrophilic pleocytosis 2 weeks into a cranial nerve involvement. And it illustrates the fact that Behçet's disease is on the spectrum of neutrophilic dermatoses. So this patient is coming and saying, I have Behçet's disease, basically. And I say that because you can imagine who's going to diagnose this patient. All the specialists are going to have a lot of disagreement because can you rule out infection? Can you rule out this or rule out that? You really need to step back and look at the whole picture. And ultimately, I will tell you this. When somebody has genital ulcers and brainstem involvement, there's not much left. And so that would be my
Mhm.
leading thought. And that leading thought, unfortunately, is very, very poor prognostic sign for the patient because he's now had all the horrible things that we try to prevent with Behçet's, which is neurological involvement and vascular involvement. And so I'm really curious how Pranay and his team were thinking about this. And I don't know how I would manage this patient. It would be beyond I would be very sad for him because I think he suffered for a long, 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 long time. But uh,
And
yeah, go ahead, Vinny.
one of the Quick question, Ravi. You're commenting about the stills versus the SAD, and do you think that in this case, the history is very like typical now that you're told everything, but the history is more typical of the SAD than stills. But like the fear thing here would play a role or significant role in like trying to differentiate. Or no, it's not a good idea.
There is nothing going for stills here, Vinny. There's no
Yeah,
fear.
absolutely.
So I don't think you need a ferritin. Yeah.
Right, thank you.
I think you need a good general internist like Pranay. Back to you, my friend. How are you thinking about this and what did you do?
Amazing discussions. You guys, all of you managed to do what we couldn't do for a couple of years. So actually, as you were saying, so this is how the patient presented. Like all of this history has been going on for years. At least I would say for 8 to 10 years. It started with uveitis that was very severe to begin with. Initially, it was attributed to patient having some spider bite, and the history was very vague in the chart because it was 10 to 15 years ago. Then the DVT incidences started to happen. So patients started to have DVT, but again, from the history, we saw that it was attributed to patient having a motor vehicle accident, and after that it got carried on. So patient had PE and then got thrombolized, and even after all the anticoagulation, patient was kind of very resistant and he was still throwing some DVTs. And then after that, the third symptom was this, that patient was having all of these mass lesions. And also at that time, because of neutrophilia, as Dr. Ravi was saying, everyone was very much concerned about patient having some type of meningitis and encephalitis. So he was empirically treated with antibiotic for a couple of days, but then they took him off of the antibiotic. And during that time, he was empirically treated with steroid, pulse dose steroid. And at that time, with the discussion of the team and the specialist, CNS vasculitis diagnosis was made. And again, patient was sent on steroid taper. And after that, patient was kind of lost to follow up, and we didn't see patient for, I would say, at least 1 to 2 years. And after that, just last year, patient again started to come to the ED again for the same complaint, leg pain and all of these issues. But a lot of time he was discharged from the ED, but one time he actually ended up on medical floors. And at that time, the most striking feature that we noted, not a lot of complaint, no neurological symptom at that time, but we noted that patient was complaining of this genital and oral ulcers. And that was kind of the clue for the team. And as you already mentioned, that when we went through the chart and we put all of the clues together, then diagnosis of Behcet syndrome slash neurobehcet was made. So it was actually a very unfortunate case for the patient because it kind of happened over the period of 10 to 12 years. And combining the whole picture was actually the main key to revealing the diagnosis. So it was actually an amazing case, but again, very unfortunate for the patient.
Yeah, I'm really curious. How did that finally happen? What was the key thing that allowed people to finally see the whole picture? What changed?
So again, like all of these symptoms, again, DVT and PE, and we couldn't find any clue what was happening. Then this neurological symptoms, and also in the MRI in the past, it was mentioned that this is one of the differential in the MRI report. And this ulcers basically like genital ulcer and oral ulcer, and one of the attendings kind of got into thinking, could it be Behcet's? And it just kind of everyone agreed on just one go that, oh yeah, it definitely makes sense, Behcet's disease. So it's basically clinical diagnosis, but we had all the clues. So just wanted to have the name from someone, and fortunately we made the diagnosis.
Yeah, I think I'm really curious to hear what Vinny is thinking, but I'll share with you all that this is the beauty. One of the really cool things about being in a global community like this is because for those of you who are practicing medicine in Turkey, you probably thought of the diagnosis in Alquat number one because you see Behcet's every Friday. But people here only see Behcet's once in a lunar once in the lunar calendar or every leap year. And so I think it's just so incredible to have a space where people are very, very familiar with it and people are less so. And unfortunately, I think this is the story of a rare diagnosis in the US. It takes a long, long time. Do you know, Pranay, how the patient is doing now and what treatment he was offered, or is that?
Yeah, so this time patient was actually started on steroid dose. Again, initially IV steroid and then tapered off of steroid. And since then, patient has been doing fine. Again, the blindness part and the other part that it's not something in our control. But compared to the past, now patient comes to the clinic and doesn't have this bad DVT in the legs and all of this. But again, by the point we were able to make the diagnosis, it was kind of already too late. So.
I really appreciate you presenting this story to us so that we're all much more ready to make this diagnosis earlier. Thank you so much, Bill. So, Vinny, what are your reflections?
Yeah, so I thank you, Pranay, for bringing this case. I really love it, and I was not very familiar, and I maybe saw one or two patients with sad hand a long time ago. So it is indeed a very like well presented with such the good history to put the things all together, and amazing girls from the CSF analysis, and always localizing the the issue, the theology in the through the imaging. So I learned a lot today. Well, thank you so much.
Yeah, I think it's a very, very difficult case, Vinny. Your job was to try to diagnose a condition that nobody could diagnose for a long time. And I think it's very, very difficult, but hopefully you take away all the lessons that I think Pranay gave us and are ready to take good care of the next patient you will likely see. So thank you so much for riding a very difficult wave in a case, and ultimately a lot for all of us to learn. But we get to relearn the major takeaways from you. Mike, to you, my friend.
Yeah, quite an amazing case. I decided not to type a lot just so I could pay attention and then imbibe a lot of the pearls that were coming out. So our task was to investigate a patient with left-sided facial weakness and then also numbness at the left side. And what jumped out right away was to localize a lesion to the brain, but such symptoms presenting specifically at the left side, what Dr. Rabih said that stuck with me is that it always begins and ends in the brain. So the pattern of the lesion also just involving the left facial muscles and then left sensory side started pointing out to the brain stem right from the get-go. And then we also got some past medical history where the patient had a hypercoagulable state and also had some recurrent vision loss. And the points that were coming that could this be a possible uveitis, or could this be just ischemic events in the retinal vessels, or could it just be some inflammatory process? And then also the recurrent hearing loss. We also started thinking about, could this be some form of inflammatory process involving the cranial nerve, or could this be also some form of ischemic events in that same area? So tying those pictures together, and then also the examination finding, which also stated that there was pairing of the eyebrow. So we're thinking that this is pointing to an upper motor neuron lesion. To tie this picture together, multi-system events, CNS events, and then some past medical history of genital ulcers. We already had a clinical syndrome of Behcet staring at us, but we still had to be sure why this patient was having a hypercoagulable state. So we looked at the various labs from the CBC platelets. We looked at the CRP. We did some other labs on the ESR, HIV, syphilis, gonorrhea. We had the inflammatory picture looking at us from the CRP and ESR, but HIV, syphilis, gonorrhea were negative. And we still went on to do the imaging. The imaging showed multifocal areas of hyperintensities, and the areas in which the lesions were just pointed out to the brainstem, just like we were thinking from the beginning. And so, not to talk too much, we've had quite an interesting case that right from the get-go presented its clinical picture to us. Labs were able to guide us right to the Besser syndrome. I have never seen that case in my country. So just like Dr. Rabih said, it's quite an interesting case to actually be a part of and to pick up this pearls from. And so this will end. Thank you very much.
Yeah, big kudos to Eugene for keeping the teaching points streamlined and efficient. And I think that's probably the way to go for such a complicated case. And I hope you all see how difficult the diagnosis of Behçet's can be, and the fact that it's really just a pattern recognition ultimately. And I think that those of you who took the time to tune in today, especially those of you who took the time to power through a difficult case like Vinny, you'll be so much more ready for the next person. And if you're in Turkey, that next person is probably tomorrow. But if you're practicing in the US, it'll take some time, but you'll be ready for it. So thank you guys. I hope you have a great rest of your day. Bye.